Distribution is the next area, and that is the movement of the drugs throughout the body. You have the blood-brain barrier. Remember, only drugs that are lipid soluble or that have transport system can cross the blood-brain barrier to a significant degree. And again, like I said, that's very important for the patient when they have an infection in the brain or meninges. You need to make sure that the medication that's going to be given can cross the blood-brain barrier. Placental drug transfer. The membranes of the placenta do not constitute an absolute barrier to the passage of drugs. So movement is determined in the same way as it is for other membranes. I think that you would be familiar with this um, concept, but you must remind your patients sometimes that medications that they take can definitely affect the baby. And of course, the big problem is that when they are if they've taken illicit drugs, especially early in the pregnancy, that they could have done a major damage to the fetus with that drug use. And of course, then we're looking at birth defects. You can have mental retardation if it affects the CNS system, gross malformations, uh, especially in the beginning of the pregnancy up to that 8th or 9th week when the organs are forming, so that they may have some gross malformations and low birth weight. And we know with cigarette smoking and the drug use, they can have low birth weight babies. Mother's use of habitual opiates will also add a drug-dependent baby, and you'll have a baby that's going through withdrawals after delivery. Protein binding. What is protein binding? Drugs can form reversal bonds with various proteins. Plasma albumin is the most abundant and important protein in the body. When patients are malnourished or um, have a disease process, their plasma albumin may be off, which can affect their protein binding capabilities, because then the transport to the target site and to the liver are going to be altered. Drug metabolism is also known as biotransformation. It is defined as the enzymatic alteration of the drug structure and most often takes place in the liver. So, because of this, it's very important um, to know the status of liver function on your patients. So, if you suspect anything from alcohol or drug use, um, it's very important that you want to have labs on your patient so that you know if the patient will be able to properly metabolize medications that you prescribe to them. Most of the drug metabolism that takes place in the liver is performed by the hepatic um, microsomal enzyme system, which is known as the P450 system. The P450 system is a set of enzymes. There's over 50 with over 100 subtypes. They are genetically determined how those enzymes work in the body. Um, and one of the principles are that you have substrates first, which allow the drug to work as it's supposed to. Then you have drugs that inhibit a specific enzyme that may decrease the metabolism and increase serum concentrations that are substrates for the enzyme, and that can cause potential drug toxicities. So if the patient has, if the drug is an inhibitor, you have to be careful because that drug may cause the patient to be toxic. You also have drugs that are inducers, which increase the rate of metabolism, and that will affect the drug effectiveness. If the drug is metabolized too quickly, it is not effective. It won't work. Many times with that, you will have to increase the dosage of the medication so that the patient will get a optimal um, level of the medication. But the more serious, of course, is the inhibitors because of the toxicity that can occur. There are special considerations with drug metabolism: age, and of course, you have to be careful with the very young and the very old, and also, of course, the induction of drug metabolizing enzymes. So, those drugs, of course, that the P450 system is very important to be aware of with the inducers and the inhibitors. First pass effect. Most drugs are metabolized in the urine. I'm sorry, in the liver, and there is a first pass effect where the majority of the med is metabolized there. That's first pass effect. So, of course, again, they need to have a healthy liver, or if there is a problem with the liver, that you adjust the medication accordingly. You do need to be aware of their nutritional status because that affects their serum albumin levels, which are important um, in the metabolism of the medications, and then competition among drugs. Um, there are some drugs that work as antagonists, so that they can affect whether the drug that you want to give uh, is going to work. So you must know how all the drugs that your patient is taking, be aware of those, and know if there's any problems with drug interactions. Also know if there's any drug use, illicit drug use, or over-the-counter drug use. I tell my patients that if they're going to do their street drugs, that their drugs are the bully, and they need to consider that they need to stop their use so that my drugs can do their job. And now, I am in psych, so it's really important that, if they're doing something that will compete with those receptors, those neurotransmitters, that they have to stop that drug use first. That's usually very important. Then we have excretion, and this is defined as the removal of the drugs from the body. Drugs and their metabolites can exit the body through urine, through sweat, through saliva, through breast milk, and expressed air. And so, of course, it's very important for your patient's renal system to be working well in order to excrete um, the medications. That is where most of it's done. But it's also important for breastfeeding moms to know that drugs can be excreted through their breast milk. So many moms, they understand during pregnancy that they need to stop medications that may cross the placenta, but they think that as soon as the baby's born, that it's okay to resume their medications. So you must make it clear to them that some or many of the meds that they could not take in pregnancy, they still can't take if they want to breastfeed their baby. And of course, we want to promote breastfeeding, but sometimes we have to do a risk benefit for everyone's health, and they may not be able to do so because of the potential for the transmission of the medication. So, again, those non renal routes of drug excretion would be the breast milk. Other non renal routes would be in the bile, in the lungs, in the sweat, and in the saliva, which are only in small amounts. Another concept to think about is the therapeutic range, and the objective of the drug dosing is to maintain the plasma drug levels within the therapeutic range. So, that's really been a job of the drug companies to make sure to figure out how often a drug should be given in order to maintain that therapeutic level. So some drugs can be given once a day. Some drugs have to be given multiple times a day. Now they're even coming out, of course, with medications that can be given, once a week. Injectables that can be given once a month or up to every 3 months. The last concept here is the half-life of the drug, and that is defined as the time required for the amount of drug in the body to decrease by 50%. It is a percentage versus amount, and this is what really helps us determine the dosing interval of the drug. So drugs with shorter half-lives have to be dosed more frequently. Those with longer half-lives, um, usually for oral medications, that usually means that they can be dosed once a day, um, but some can be dosed, once a week. Typically, most of the meds I deal with are once a day, but what that does help me to know with the half-life is, of course, um, if the patient will have any symptoms if they don't take the meds uh, and forget a couple of days. Examples for me would be um, in the psychiatric meds would be Prozac, which has a half-life of 4 to 6 days, as opposed to Paxil or Effexor, which have very short half-lives. So I know with my patients with the Paxil or Effexor, they're going to they may have what we call discontinuation syndrome within a day or two if they skip or forget their medications or run out of their medications. And I've certainly had it happen and had calls from patients that didn't get their meds and now are feeling those effects of the discontinuation, which are usually being off balance, have diarrhea. They just really don't feel well. Um, it's not anything that's going to seriously hurt them, but they definitely don't feel well. But if the patient's on Prozac, I'd love for that for the teenagers because if they take their meds say on Friday and then they go somewhere on the weekend and they forget to bring it with them, they can taking their med again on Monday will be no problem because with the long half-life, they will not have any reactions that are going to be bothersome for them. But think about things like your epi and things you would give in the hospital that have very short, very, very short half-lives. They may have 30 minutes uh, or an hour. So you're going to be dosing those you can dose those quite frequently. So that is a big consideration when you want to give a med to a patient. When you think about compliance of the medications, looking at the half-life. It's also important when you're thinking about maybe weaning a patient off of a medication. If they have a short half-life, um, you have to be careful because of the discontinuation, but um, that may um, prolong the um, discontinuation. When I've had patients on a medication for years, we have to do a very slow taper because of that short half-life. But say of the med again like Prozac with a long half-life, I don't have to, you almost don't have to do a taper because the med is going to naturally taper itself if you just start to decrease the dose because of the long half-life. Um, another consideration uh, with the half-lives is also if you have to do blood levels. So let's say on a medication like levothyroxine, um, it also has a half-life of about 7 days. So if you want to check for um, blood levels when you're first putting a patient on the medication, and you need to check to see if they're at a therapeutic level for the levothyroxine, that their TSH is now leveling out. Um, Actually, you will have to wait at least a week to recheck the patient because otherwise you won't get a true level of where the new dose, if you've changed the dose, where that's at. So every time you change the dose, you have to wait a week. Well, when you think about from the hospital setting, you're used to doing peaks and troughs, and those are done, on a daily basis because those meds have very short half-lives, and you want to make sure that there's no toxicity or that, you're in a therapeutic range. So now I have a few questions that come with the set. So you're preparing to administer epi, severe allergic reaction. Which route of administration should the nurse use to provide the fastest and most complete absorption of epi? So with this question, you should have picked the IV route. That would be the fastest. I talked about that earlier. Route to give a patient a medication uh, if there's a severe reaction. If it's not a severe reaction and they're just having maybe some itching, you might be able to give them another medication. You might just be able to give them Benadryl or give them some a corticosteroid if that's needed. And that could be in an oral route if there's a mild reaction. But for the severe reaction, you want the quickest, and the quickest would be IV. Next question. Um, which patient here is at the highest risk for slow drug metabolism? And the correct answer here is C. It's going to be the 56-year-old with the chronic hepatic disease. Why? Because his liver is not going to be working as well, and the liver is again the major organ that does metabolism of medications. The 2-year-old, by the time kids are 2, their their organs are working close to adult level, and so he should be pretty good. The 14-year-old is definitely the healthy one and taking 4 medications. You're not looking at an issue for slow metabolism there. You would just want to make sure that the medications that are given don't have any major drug to drug interactions. The 76-year-old, while they're older, and that is a consideration for drug metabolism because of just aging with um, their organs, um, there's no indication of any chronic illness that would interfere. Nothing, it doesn't indicate anything's going on with the liver or the kidneys. So that is why C is the best answer here.